Hello everyone and welcome to our module on ventilation and perfusion. In the video on hypoxia, I talked about the AA gradient and I talked about how this can help you determine the cause of hypoxemia. Also in that video, I mentioned that when there was hypoxemia and a high or increased AA gradient, this meant that the alveoli can't get oxygen to the blood or that the blood is not going to working alveoli. And there are many diseases that cause hypoxemia with a high AA gradient. These include things you are familiar with like pneumonia and pulmonary embolism and interstitial fibrosis. But underlying all of those disorders are three basic mechanisms that cause hypoxia. The first one is called diffusion limitation, the second one is shunt, and the third one is VQ mismatch. So in this video, we'll go through all three of these mechanisms to help you understand how they lead to hypoxemia. Now, closely related with these three mechanisms is another lung process called dead space. Dead space does not cause hypoxemia, but it does cause hypercapnia or an increased CO2 level. So in this video, we'll also go through dead space and the consequences of dead space as part of a disease process. The first cause of hypoxemia with a high AA gradient is diffusion limitation, and this is fairly straightforward to understand. There is oxygen in the alveoli, and that oxygen must diffuse into the bloodstream and be taken away by red cells. If there is a barrier to that diffusion, then oxygen is not taken up and hypoxemia develops with a high AA gradient. Now you might think that hypercapnia would also develop. However, it turns out that diffusion barriers have much less effect on carbon dioxide than on oxygen, so hypercapnia does not occur in diffusion limitation, only hypoxemia. And the classic example of a disease that involves diffusion limitation is pulmonary fibrosis. This is an X-ray from a patient with pulmonary fibrosis on the screen. There are many causes of pulmonary fibrosis, but they all lead to hypoxemia from limited diffusion of oxygen into the blood. Now, interestingly, patients with pulmonary fibrosis also have hypercapnia. The reason for this is not diffusion limitation. It's because when alveolar capillaries are destroyed, dead space occurs. This is where there is ventilation of the lungs without perfusion, and the dead space causes hypercapnia. And we're going to talk more about dead space later, but I just want to point out to you here that that is the cause of hypercapnia in patients with pulmonary fibrosis. To understand the other mechanisms of hypoxemia with a high AA gradient, we need to understand ventilation and perfusion. So ideally, the lung would have ventilation matched to perfusion. In other words, the ratio of ventilation to perfusion of the lungs would be 1, so that every time an air molecule moves into the lungs, there is a matched molecule of blood ready to scoop up the oxygen and take it away. However, in normal lungs, ventilation is about 4 liters per minute and blood flow is about 5 liters per minute. So in the normal lung, the VQ ratio overall for the entire lung is 0.8. And as we will see, in some disease states, VQ can get either too high or too low for the lungs, and this leads to ventilation that is inefficient. Let's start by talking about what happens when the VQ ratio becomes reduced, in other words, when it becomes less than 1. This means that there is reduced ventilation relative to perfusion in the lungs. It means that perfusion is being wasted. Blood is going where there's not enough ventilation and not enough oxygen present to properly oxygenate the blood. When a segment of the lungs has an extreme reduction in VQ, so extreme that the VQ ratio becomes 0, we call that shunting. And the reason we call it shunting is because the physiology is the same as if blood were being shunted around the lungs. You have venous blood that is traveling to the arterial system without passing an area of ventilation. In other words, without being oxygenated. This is going to cause hypoxemia the same way you would get hypoxemia if there were blood bypassing the lungs and not going past alveoli whatsoever. There are two subtypes of shunting, anatomic shunting and physiologic shunting. Anatomic shunting occurs when blood bypasses the lungs and alveoli completely. This often occurs when there's some type of heart defect, for example, in babies born with congenital heart disease. If they have a large VSD, for example, there can be intracardiac shunting of blood so that blood bypasses the lungs. This can also be seen in rare circumstances when patients have pulmonary AVMs, which are vascular malformations that allow blood to bypass the lungs. Physiologic shunting occurs when blood does go to the alveoli, but the alveoli aren't working properly. In other words, non-ventilated alveoli or under-ventilated alveoli are being perfused. And one example of this that's easy to imagine in your mind is atelectasis. When atelectasis occurs, there are collapsed airways, and if blood flows past the collapsed airways, it will not be able to pick up oxygen normally. To understand the physiology of shunting, let's take a look at two alveoli and two capillary in a diagram that I'll come back to a number of times in this video. So imagine that air flows into this lung unit, and it can either go to the alveoli on the left side of the screen or the one on the right. And each alveoli has a capillary where blood flows past the alveolus to pick up oxygen. In this example on the screen, the alveoli are working normally, and so are the capillaries. So blood leaves the capillaries 99% saturated with oxygen, and when the blood mixes together, we have arterial blood that is 99% saturated with oxygen and normal. In the case of shunting, you have one alveolus, as shown on the left side of the screen here, that is receiving no ventilation. For that alveolus, the VQ ratio is 0. Blood that flows past this alveolus will receive no oxygen, so it will leave the capillary associated with that alveolus with an oxygen saturation that is the same as venous blood. It will be less than 99%. Now the other alveoli in the lungs, like the one on the right side of the screen, are working normally, so they fully saturate blood with oxygen until it's 99% saturated. However, when the streams mix, you will have hypoxemia. You will have a reduced oxygen content of the arterial blood. Now, an important point about shunting is written on the top right side of the screen. If this patient increases his or her respiratory rate, in other words, if the patient begins to hyperventilate because of hypoxemia, this will not resolve the low PaO2. So why is that the case? Well, hyperventilation is going to put more gas in and out of this healthy alveolus on the right side of the screen. However, at baseline, that alveolus is already doing all it can. It's fully saturating the blood with oxygen. So hyperventilation cannot raise the oxygen saturation above 99%, and therefore hyperventilation is not going to resolve the hypoxemia in shunt. The only way to resolve hypoxemia in shunting is to resolve the shunt. So for example, a mucus plug of a bronchus often causes shunting. You need to suction out that mucus and get this alveolus on the left side of the screen to oxygenate normally. That's the only way you're going to resolve the shunting. Hyperventilating the healthy alveoli will not do anything for oxygen levels. Hyperventilation will, however, usually keep the CO2 level normal in most cases of shunt, so let's talk about that. So if this patient hyperventilates, more gas will go in and out of this healthy alveolus on the right side of the screen. That won't do anything for the oxygen level, but that will pull more CO2 out of the blood flowing past this capillary. So in most cases of shunting, you do not see hypercapnia, and that's because the patient hyperventilates from hypoxemia, and that usually brings the CO2 level down to normal, even though the hypoxemia persists. Now let's talk about what happens when the VQ ratio becomes greater than 1. In this situation, you have reduced perfusion relative to ventilation. In other words, ventilation is being wasted and gas is going to places in the lung where there is insufficient blood flow to make use of the oxygen. The extreme situation of an increase in VQ ratio is called dead space. In this situation, the blood flow or Q is 0, so the VQ ratio becomes infinite. And just like there are two types of shunting, there are two types of dead space: anatomic dead space and physiologic dead space. Anatomic dead space is the portions of the lung, the volumes of the lung that occur in conducting portions of the respiratory tract. These are parts of the respiratory tract that need to fill up with air with each breath, but they don't participate in gas exchange. So for example, your nose and your trachea must be filled with air with each breath, but they don't participate in gas exchange. Physiologic dead space is the anatomic dead space plus the volume of alveoli that don't exchange gas. It turns out that not every alveolus in your lungs exchanges gas just as well as all the other alveoli. Some alveoli have insufficient perfusion. The apex is the largest contributor. We'll talk more about this later. And so for this reason, the physiologic dead space is always greater than the anatomic dead space. So as you can imagine, in many disease states, the amount of physiologic dead space will increase. There are many disease conditions where there's poor perfusion of the alveoli, and these can result in a rise in dead space. For example, we've already talked about fibrosis, and fibrosis can lead to increased dead space. This is because in fibrosis there may be destruction of the alveolar capillaries, and therefore you can have alveoli that are ventilated but underperfused or not perfused at all. To understand dead space better, let's go back to our model of two alveoli next to each other. One of the easiest causes of dead space to wrap your mind around is a pulmonary embolism. So let's imagine we have a blood clot in this capillary, and it's not allowing any blood to flow through this capillary. This will create dead space in this alveolus on the left side of the screen because that alveolus is ventilated, but there is no perfusion. It has a VQ ratio of infinity. The alveolus on the right side of the screen, however, is working normally, so it fully saturates the blood with oxygen. And what this means is that the oxygen level in the arterial side of the body will be 99% or normal. So this is an important point. In cases of pure dead space, there is no hypoxemia, and that's because the healthy alveoli fully oxygenate the blood, and the sick alveoli do not deliver any blood to the arterial system. The main problem with dead space is that the carbon dioxide level goes up. Why is that the case? Well, every time you take in a breath, you're going to waste a ton of that ventilation. It's going to go to this alveolus on the left side of the screen here that has no perfusion. This is going to make it very difficult for the lungs to remove CO2 because they're wasting lots of their ventilation on alveoli that do nothing for the removal of CO2. So a key point here is that hypercapnia or elevated CO2 is very common in dead space, and in pure dead space, hypoxemia does not occur. Now, I said pure dead space cannot cause hypoxemia, but as you likely know, many patients with pulmonary embolism do have hypoxemia. So let's talk about how that happens. So let's imagine we have our blood clot here and we have no blood flowing through this capillary on the left side of the screen. So the VQ ratio on the left side of the screen is infinity. Well, because no blood is flowing through the left side of the screen, more blood will be diverted to healthy alveoli like the one on the right side of the screen. This can lead to a situation where the blood flow, or Q, is very high through the healthy capillaries. And this can lead to a situation where the healthy alveoli have a VQ ratio that becomes reduced. And this is called VQ mismatch. You now have some alveoli with a VQ ratio that's high, like infinity, and other alveoli where the VQ ratio is reduced, like on the right side of the screen. And when the VQ ratio becomes reduced, you now have a situation similar to what we talked about for shunt, where blood cannot be fully oxygenated. So therefore, instead of 99% coming out of this healthy alveolus, you would now have something less than 99%, and this will lead to hypoxemia. So dead space can lead to hypoxemia if there is enough blood flow diverted to the healthy capillaries such that VQ mismatch occurs. So let's talk about VQ mismatch, which is our third underlying mechanism of hypoxemia with a high AA gradient. VQ mismatch is an intermediate state between a VQ of 0, which is a shunt, and a VQ of infinity, which is dead space. In VQ mismatch, some portions of the lung have a low VQ and others have a high VQ. Now let me clear up a point of confusion. You may be aware that in both dead space and shunt, ventilation and perfusion are not matched. So you may be inclined to call shunt a form of VQ mismatch or dead space a form of VQ mismatch. While that's technically correct, when pulmonologists refer to VQ mismatch, they are not talking about shunt or dead space. Pulmonologists consider shunt and dead space separate mechanisms of hypoxemia, and they reserve the term VQ mismatch for this intermediate state. When you have this intermediate state of VQ mismatch, there will be inadequate ventilation. This will lead to reduced oxygenation of blood, and very similar to the situation in a shunt, if the patient increases their respiratory rate, they can then blow off the CO2, so the CO2 is often normal. So one common condition that can lead to hypoxemia through VQ mismatch is pulmonary edema. In pulmonary edema, you have some liquid in an alveolus, as is shown on the left side of the screen here. That is going to lead to poor ventilation of that alveolus. So in the alveolus on the left side of the screen here, we have a reduced VQ ratio of less than 1. It's not 0 like a shunt, but it's less than 1. And then over here on the right side of the screen, we have a normal alveolus with a VQ ratio equal to 1. So thus we have mismatched VQ ratios in these two alveoli shown on the screen here. The one on the left side is going to deliver blood to the arterial system that is under-oxygenated. The one on the right side will normally oxygenate blood, and when the two streams mix, you will have hypoxemia through the mechanism of VQ mismatch, and this is distinct from shunt and dead space. Now that we've talked about shunting and VQ mismatch and dead space, let's talk in general about inadequate gas exchange. When you're faced with a patient in respiratory distress or a patient with hypoxemia or hypercapnia, any of these underlying mechanisms may be playing a role. So how are you going to determine the underlying mechanism? Well, there are two major clues to the underlying mechanism. Those are the response to 100% oxygen and the presence or absence of hypercapnia. So let's talk about those in the next few slides. If a patient has hypoxemia and you administer 100% oxygen and the cause of the hypoxemia is shunting or a VQ ratio of 0, the hypoxemia will not correct with 100% oxygen. This is because in the case of shunting, the functioning alveoli are already extracting the maximum O2, so increasing the alveolar O2 does not help those alveoli to work better. On the other hand, the sick alveoli do not receive any of the 100% O2 because they have decreased ventilation. We can make this easier to understand if we go back to our diagram of shunting. So in shunting, we've got the alveolus on the left side of the screen, which is not being ventilated, and therefore it's delivering hypoxemic blood into the arterial system. The alveolus on the right side of the screen, however, is working normally, and it's extracting all the oxygen it can. So even if you administer 100% oxygen, it won't fix this problem, because the alveolus on the right side of the screen will still only pick up until it's 99% saturated. Nothing will change in the alveolus on the left side of the screen, and the hypoxemia will persist. So a key point is hypoxemia that does not correct with 100% oxygen suggests that shunting is the underlying mechanism. Other causes of hypoxemia, like dead space and VQ mismatch, will correct if you administer 100% oxygen to the patient. That's because in these settings, increasing the O2 content in the alveoli will lead to an increased PaO2 in the arterial system. Let's go back to our diagram of dead space, and as I told you before, dead space in and of itself cannot cause hypoxemia. However, if the dead space is significant, it can increase the blood flow so much in the healthy alveoli that the VQ ratio in those places can become less than 1, and this creates a setting of VQ mismatch. So let's imagine that we have dead space that has led to VQ mismatch such that the VQ ratio is infinity in the alveolus on the left, but it's less than 1 in the alveolus on the right, and the reason it's less than 1 is because the Q is very, very high, because all the blood is being pushed away from the alveolus on the left and through the one on the right side of the screen. In this setting, we could get hypoxemia if we were breathing room air, which is 21% oxygen. However, if we change to 100% oxygen, then we increase the oxygenation of that capillary on the right side of the screen, and that can resolve the hypoxemia. So therefore, hypoxemia caused by VQ mismatch from dead space will correct with 100% oxygen. And the same thing is true if you have VQ mismatch for any other reason, including pulmonary edema. In this setting, we have hypoxemic blood leaving the capillary on the left side of the screen when the patient is breathing 21% room air oxygen. If we increase to 100% oxygen, however, then we fully oxygenate the blood on the left side of the screen and we resolve the hypoxemia. The second important clue to the underlying mechanism of inadequate gas exchange is the presence or absence of hypercapnia. And in order to understand this clue, we have to understand the causes of an elevated PaCO2. So on the bottom of the screen, I've shown you an important equation. It says that the amount of carbon dioxide in the arteries is proportional to the CO2 production divided by the alveolar ventilation. And this should make sense to you. If you are producing more CO2, that will obviously raise the CO2 content of blood. And if you ventilate your lungs more, that will reduce the CO2 content of blood. Now, the alveolar ventilation is equal to the tidal volume minus the dead space. So if you understand this equation, it's now very easy to understand the causes of an increased PaCO2. You can have hypercapnia when you have increased production of carbon dioxide, as occurs in fever or any other cause of increased metabolic rate. You can also have a rise in the CO2 level when you have decreased ventilation, as occurs when there's hypoventilation for any reason. And then finally, and most important to this video, you can have hypercapnia when you have increased dead space. Dead space is in this equation for the PaCO2. It's in the denominator. So when the dead space rises, that is going to lead to a rise in PaCO2. So dead space, as we talked about earlier, is a classic cause of hypercapnia, because when patients have dead space, even when they ventilate, they're unable to blow off their CO2 because lots of their ventilation is wasted by going to alveoli where there is no perfusion. Remember, in dead space, the VQ ratio is infinity because there's no blood flow. It's a perfusion problem, so ventilation gets wasted. And you can see that in this equation at the bottom of the screen here. When the dead space term goes up here, that is going to increase the PaCO2 by this equation, and it also makes sense by the conceptual image we talked about before. I'll go back here to our diagram. When patients with dead space hyperventilate, the ventilation is wasted on this alveolus on the left side of the screen that has no perfusion, and for this reason, carbon dioxide doesn't get effectively removed. And as I said before, the main problem in dead space is hypercapnia. Shunting and VQ mismatch, on the other hand, rarely cause hypercapnia, and the reason is because in these conditions, increased ventilation will resolve the hypercapnia. Here's our shunting diagram. When this patient hyperventilates, none of the ventilation is going to be wasted on this sick alveolus on the left side of the screen because it's obstructed. So all of the ventilation will go to the healthy alveolus, and therefore this will remove carbon dioxide effectively, and this prevents hypercapnia in cases of shunting. And the same thing can happen in VQ mismatch situations like pulmonary edema. When this patient hyperventilates, less ventilation will go to the sick alveolus because it's filled with fluid. So more of it will go to the healthy alveolus, and this will pull off carbon dioxide from the body and prevent hypercapnia. So I've summarized these points here. In shunting and VQ mismatch, hypoxemia stimulates hyperventilation, an increase in the respiratory rate, and this increases alveolar ventilation, which is the term at the bottom of the PaCO2 equation. Conceptually, this means that the healthy alveoli are getting more ventilated, and therefore they're able to compensate and pull off the CO2 despite having some alveoli in the lungs that are sick. This leads to normal CO2 excretion, and for this reason you rarely see hypercapnia when shunting or VQ mismatch are the mechanism involved in the pathology. The table on this slide summarizes everything you want to remember about mechanisms of hypoxemia with a high AA gradient. Basically, if you know what's on this slide, you can answer the majority of board questions about these mechanisms. So at the beginning of this video, we talked about diffusion limitation that causes hypoxemia but not hypercapnia, and it responds to 100% oxygen. The hallmark of shunt is hypoxemia that does not respond to 100% oxygen. You always want to remember that. And shunt does not affect carbon dioxide levels. VQ mismatch is the most common overall cause of hypoxemia with a high AA gradient. It responds to 100% oxygen, and in and of itself, it does not affect carbon dioxide levels. And finally, we talked about dead space, which by itself does not cause hypoxemia. It may cause hypoxemia if it leads to VQ mismatch, but isolated dead space should not cause hypoxemia. But it does cause hypercapnia, and in board questions, when you're asked for a mechanism of hypercapnia, they are often looking for dead space. And then obviously the response to 100% oxygen is not relevant here because dead space does not cause hypoxemia. Now let me clear up one common point of confusion regarding these mechanisms of hypoxemia. The thing that's confusing as a student is that in many disease processes, more than one mechanism of hypoxemia is occurring. So for example, very few lung diseases involve pure shunt or pure dead space or pure VQ mismatch. Often more than one is going on at the same time. For example, we've been talking about pulmonary embolism in this video, and in pulmonary embolism, dead space goes up, as we have discussed. So you would think since dead space goes up that the patient should have hypercapnia and a high CO2 level. However, most patients with PE actually have a low CO2 level. And the reason they usually have a low CO2 level is because the degree of dead space is often relatively modest, and patients significantly increase their respiratory rate in the setting of pulmonary embolism, thus they hyperventilate, and that leads to a low CO2. So even though there's dead space in PE, the physiology doesn't work out exactly like dead space physiology. And the same thing is true for pneumonia and COPD and many other lung diseases. Often multiple mechanisms of hypoxemia are at play. These mechanisms are just designed to explain what's going on in different parts of the lung. Rarely do they completely explain one disease process. I'll finish with a couple final points about ventilation and perfusion. The apex of the lungs have the least blood flow. That's because blood has to push up against gravity to reach the top of the lungs. The apex of the lungs also has the least ventilation. The base of the lungs has the most blood flow and the most ventilation, so they both decrease going from bottom to top. However, it turns out that blood flow decreases more, so the VQ ratio changes as you go from the base of the lungs to the apex. At the apex, the VQ ratio is greater than 3. There's lots of relative ventilation. This means there's going to be a relatively high oxygen content at the top of the lungs and a low CO2 level. At the base of the lungs, the VQ ratio is less than 6. That's because there's low ventilation relative to perfusion, so you can see a lower oxygen level here and a higher CO2 level here. Overall, however, as I said before, the VQ ratio for the lungs is 0.8. And a very high-yield clinical correlation of the change in VQ ratio through the lungs is tuberculosis. Tuberculosis has an affinity for highly oxygenated portions of the body, and it likes to infect the upper lobes of the lungs because that is where the VQ ratio is highest and the most oxygen is available. It would be nice if the mechanisms of hypoxemia like VQ mismatch and shunting tied in with diseases. In other words, it would be really nice if we could say heart failure patients have shunting, pneumonia patients have VQ mismatch or something like this. However, it turns out that most clinical diseases like COPD, pneumonia, and heart failure have hypoxemia from multiple mechanisms. For example, pneumonia can cause VQ mismatch but also shunting. COPD can cause alveoli and blood vessel destruction, so this can lead to problems with both ventilation and perfusion. A few examples that are worth knowing, however, for step 1 of your boards are that if a patient has an intracardiac shunt, like a VSD, this is a pure shunt mechanism, and this usually will not correct with oxygen. If a child inhales a peanut and it gets stuck in their lungs, this leads to a VQ ratio of 0 in that portion of the lungs. And as we discussed earlier, pulmonary embolism is a classic cause of a VQ ratio of infinity. When you exercise, you also change your VQ ratio. As you know, if you've ever exercised yourself, your respiratory rate goes up, but so does your heart rate and your blood flow. So there's more blood flow and more ventilation when you exercise. However, it turns out that the increase in ventilation is greater than the increase in blood flow on a relative basis, and therefore the VQ ratio approaches 1 with exercise. Our final topic for this video is lung pressure zones. Because of gravity, there is more hydrostatic pressure in the arteries and the veins at the bottom of the lungs compared to the top. In other words, as you move up the lungs, the hydrostatic pressure in the arteries and veins, PA and PV, both fall. Alveolar pressure, on the other hand, the pressure inside the air sacs, is the same throughout the lungs. So in theory, at the apex, you can have a P big A that can become greater than P little a and little v, and this means that you can compress the vessels. In other words, this can lead to less blood flow or perfusion and a very high VQ ratio and more dead space. So because of this phenomena, physiologists like to classify the zones of the lung into 3 zones. Let's talk about them one at a time. So at the base of the lungs, you have a pressure in the arteries and the veins that is higher than the pressure in the alveoli. This means that the blood vessels will be fully distended and blood will flow normally. At the apex of the lungs, this is called zone 1. In this setting, the pressure in the alveoli is higher than the pressure in both the arteries and the veins. This is going to compress the blood vessels and result in no blood flowing through the vessels at the top of the lungs. In zone 2, in the middle of the lungs, the pressure in the arteries is higher than the pressure in the alveoli, but the pressure in the alveoli is greater than the pressure in the veins. What this is going to do is compress the veins, and you're going to get pulsatile flow. When the right ventricle contracts, it will raise the pressure in the artery enough to push some blood into those collapsed veins, but in diastole there won't be flow into the veins. Now in reality, in healthy lungs, almost all of the lung tissue is zone 3 with just a little bit of zone 2, and there's almost no zone 1. However, in pathologic states, you can get more zone 1 physiology. This is especially true in patients who are on ventilators. In patients who are on ventilators, the pressure in the alveoli can get very high, and this can lead to zone 1 physiology. And that concludes our video on ventilation and perfusion.